Dear colleagues, welcome to the ESMO 21 exchange meeting, highlights on urogenital cancers. Welcome and glad you tuned in. We have organized this scientific session. So it's science we are talking about. We are talking about the highlights of the ESMO Congress. But of course, this event could not take place without our sponsors, who helped us to organize the meeting and help us with financial support. I have to stress, however, that the sponsors had no influence whatsoever on the selection of the speakers, nor the selection of the abstracts, nor of the content we transfer. So it's really an independent scientific meeting, independent of the sponsors, but of course we are grateful for their support. I have to mention, however, that in the program, we might address some drugs and the use of some drugs outside the license indication in Switzerland. Because it's a science meeting, we are allowed to do that. So, but please take care. Sometimes we discuss drugs that will hopefully impact on the care of our patients tomorrow, but they might not be licensed tomorrow for this use. So here are our speakers. Aurelius Omlin, I don't have to introduce him too long because you all know him. He will present and discuss the prostate cancer. Ursula Vogel, same story, you all know her. She will present and discuss renal cell cancer. And again, with Anja Lorch, you all know her. She will present and discuss bladder cancer. So for the first half an hour, we start with prostate cancer, then move on to renal cell cancer, move on to bladder cancer, and I will do a wrap up at the end of the session. Each session will be split in two. The first part will be a presentation of the highlights, and the second part will be case discussion. Please note that all sessions will be recorded. All presentations will be in English to allow also colleagues from the Romandie and from Ticino to tune in. You will be muted during the entire session, but will be able to ask questions via the chat. I will pick up your question and present it to the speakers, and we'll be able to discuss your question. So do tune in. We are happy to receive chats and questions via chat, and we will discuss them during the meeting. There will be also voting questions, especially in the cases you will have voting questions where we try to address practical questions you will encounter tomorrow in your clinical practice, and you'll be able to vote. So you can, and we are happy if you do participate by voting. So do participate and cast your vote whenever there is you are asked to do so. And with much further ado, I think we jump right into the first presentation, and the presentation is now to Aurelius Omlin, who will present us the highlights and the cases for prostate cancer. Aurelius, thank you very much for taking part, and thank you very much for being a speaker today.
Thank you, Jörg, for the introduction. I hope you can see the slides. I'm excited to be part of that panel. Thank you for the invitation. And we have exciting news in prostate cancer. We had at ESMO 2 presidential sessions on advanced prostate cancer, and I will show you the highlights of these sessions. As Jörg mentioned, some of the indications I will discuss are off-label, so that's important to remember. And I have also some conflicts of interests that I would like to share. So what are the highlights? In my opinion, of course, there's always a lot more that we could discuss, but for tonight, we focused on the really practice-changing aspects in advanced prostate cancer. We have Stampede once again, and many more presentations of Stampede will follow. With 2 years of abiraterone in locally advanced prostate cancer in addition to ADT. In metastatic hormone-sensitive prostate cancer, we have an update on the Prism trial, which was already shown at ASCO, now showing the overall survival data. And we have an update on the Arches trial with the final overall survival data. The primary endpoint was not OS in this trial. And in metastatic CRPC, I picked vision because it was an important presentation at ASCO with the radiographic progression-free survival and overall survival data. And now we also have quality of life data for lutetium PSMA in mCRPC. So this is my favorite slide that I always like to show, the treatment landscape for advanced or for prostate cancer in general, and it is getting more and more complicated. I just want to show you where the abstracts that I'm going to show are placed. We start with STAMPEDE, and STAMPEDE is or includes a mixed population of patients. And now they focused really on high-risk locally advanced prostate cancer patients with either node positive on scans, and this is not PSMA PET, or 2 out of 3 high-risk features, T3, T4, Gleason 8 to 10, or PSA more than 40, or patients who had already received local treatment but were relapsing with PSA rise, or are node positive after local treatment. So again, a mixed population, but in a much earlier space. Then the metastatic hormone sensitive presentations, PIS1 and ARCHES, are focused here and on synchronous and metachronous metastatic patients. And finally, we have the vision data here in the late and advanced CRPC space. So starting with STAMPEDE, you have seen this slide in previous presentations, but this one now focused really on the M0 population. And in the presidential session, when Gerd Attard presented the STAMPEDE data, he spent about half of his presentation time on explaining the background and what kind of patients were included. So they were all non-metastatic on CT and bone scan, absolutely no PSMA PET used. Newly diagnosed, as I mentioned, node positive or high risk, really high risk, so UK high risk, or relapsing after previous radiotherapy or radical prostatectomy, node positive, or with these PSA criteria, PSA of more than 4 and a doubling time of less than 6 months, or PSA more than 20. And how are they now split for the data that we are going to see today? 58% of the patients, so the majority, are these high risk locally advanced. 40% are node positive, but he didn't give the details of which patients were newly diagnosed or which patients were relapsing and node positive. And 3% were in this PSA rise after local treatment setting. So a complicated slide, and the STAMPEDE team has published the statistical plan because previously they used to combine the data of the metastatic patients and non-metastatic patients. We have seen that many times, and then they show subgroups, but this time now they have really a new statistical plan to separately look at the M0 patients. And as in STAMPEDE, always there's a control arm, and the control arm was ADT for 3 years plus radiotherapy. And then patients were randomized to, in the initial period here, you see 2011 to 13, 2 years of abiraterone and prednisone, or later on, a later arm was the combination of abiraterone, prednisone plus enzalutamide, also in the non-metastatic patients only for 2 years. And of course, always standard of care, and the standard of care is always these 3 years of ADT plus radiotherapy. And these are the main results. I don't want to bore you with a lot of survival curves. This is the metastasis-free survival. In this graph, you see metastasis-free survival for ADT plus ABI and versus ADT. And remember, only 2 years of ABI, and you see the curves separate at about 1.5 years, but continue to separate, although ABI and PRED was stopped after 2 years. The hazard ratio really impressive, 0.54, and a very significant p-value. And the same was really shown for ADT plus ABI plus ENZA. Same hazard ratio. The follow-up is of course shorter because this arm was added later in the STAMPEDE protocol. And not only metastasis-free survival, which is important, but also for overall survival. And here they pooled the patients, and you see here at the numbers of risk, it's really almost 2,000 patients that were included. Also for overall survival, there's a significant improvement. I put it at the bottom line. In locally advanced or node positive patients, 2 years of abiraterone plus prednisone Probably enzalutamide in combination doesn't really add much, but they didn't go into details there. Plus ADT, plus minus radiotherapy results in an absolute 6-year benefit in metastasis-free survival of 13%. The number needed to treat is 8, so you need to give 8 patients 2 years of abiraterone and prednisone, so that you have one event less for MFS. And for overall survival, it's a 9-year absolute benefit at 6 years. Number needed to treat is 11. For oncology, I would say this is really, these are low number needed to treat. So you need a few patients to get a big benefit for patients that have potentially many years to live. This is the update for STAMPEDE. And now for metastatic hormone-sensitive prostate cancer. This slide looks complicated, but is in fact quite easy. We have synchronous metastatic patients, high volume and low volume, and we have metachronous metastatic patients, high volume and low volume. Synchronous means the primary tumor is untreated. These patients are newly diagnosed, either high volume disease. This is probably not a very common event, but we see these patients ever so often that are diagnosed with extensive bone mets. What we see much more, especially now with PSMA PET in the primary staging, is patients that are newly diagnosed, the primary is untreated, and they have on PSMA PET either lymph nodes or bone lesions. Whether they are metastases or not can be debated, but this is definitely a very important space and growing with the new PSMA PET imaging. For metachronous high volume patients, this is something we probably see if a patient was lost to follow up or did not want to have follow up. The primary was treated and the patient eventually is diagnosed with extensive metastatic disease. I would say this is quite uncommon. What is also common, and we have experience here for quite a number of years now, is the biochemical relapse. Patient has a local treatment of the primary and later a PSA rise. And with the new imaging, and first it was choline PET, now it is PSMA PET, we find low volume of metastatic disease. So this is the background for the Arches, Titan, and piece 1 that I'm going to show. Very briefly, the design, you have seen that for the Titan trial, which I'm going to show, because Titan also presented final overall survival data this year, not at ESMO, and Arches, which was presented at ESMO. So these were all metastatic hormone-sensitive patients, most of them high volume, both trials 63%, and most of the patients were synchronous metastatic, 80% in Titan, 66% in Arches. But it also means that in Arches, a relevant proportion of the patients were actually metachronous, so relapsing after local treatment. Here, for these trials, docetaxel was allowed, so you could start ADT plus 6 cycles of docetaxel and then include patients for APA and ENZA, or ADT alone, so patients were randomized. For Titan, the primary endpoints were rPFS and OS. For Arches, the primary endpoint was rPFS. We have seen all these data before, now we just saw updates in 2021. And this is the summary for these trials, and I would say the results are almost identical. The patient populations are not identical, but very similar. But when you look at overall survival, the hazard ratio is really similar, 0.66 and 6.5. Here for Titan, the control arm reached an overall survival of 52 months, not reached in the experimental arm and not reached in Arches. And also for radiographic progression-free survival, hazard ratio 0.39, 0.48. The control arm alone, time from start of ADT to radiographic progression, 22 and 19 months, and not reached for the experimental arm. For Arches, this was important because we have previously only seen rPFS data. Now we know that also overall survival is in the same ballpark as for Titan. Now for the piece 1 trial that we have seen at ASCO already. It is unfortunately a very complicated trial with 4 arms, and we have only seen only part results. Important for piece 1 is that it only included patients with synchronous metastatic hormone-sensitive prostate cancer. So all were newly diagnosed, at least 1 bone lesion on CT or bone scan. Again, no PSMA PET diagnostics here. the majority high volume. And for docetaxel, it was a bit complicated. Standard of care initially was only ADT. Later, docetaxel was allowed based on charted and stampede data. And later on, docetaxel was even mandatory. So overall, 60% of the patients received docetaxel, 40% did not. Then there's an arm with standard of care, as shown up here, plus ABI. Then an arm standard of care plus radiotherapy of the prostate, but this time 74 gray in 37 fractions. So not a stampede protocol, but a more classical local radiotherapy protocol. And also the pelvic lymph nodes could be included in the radiotherapy field. And then there's a combination of all of these options, standard of care plus ABI-PRED plus radiotherapy of the prostate. More than 1,000 patients were included. The median age, 66 years. So that's quite a young group of patients with synchronous metastatic prostate cancer. Most of them had a good ECOG performance status of 70% had 0, and visceral metastases, so liver or lung, were shown in 12% of patients. There are subgroups of these trials. We have not seen any radiotherapy data at the moment. It only focused on systemic treatment, and Karim Fisasi at ESMO primarily presented the data on the ADT plus docetaxel population. And this is the main result. In red, the triplet, we call it triplet. So that's androgen deprivation plus 6 cycles of docetaxel plus abiraterone, but not limited to 2 years, but really indefinitely until progression. Or the doublet here, ADT plus 6 cycles of docetaxel. And you see a significant improvement, a hazard ratio of 0.75, which is impressive. And these are not months, but these are years, median overall survival. And you see here, this is about 700 patients that have had ADT plus docetaxel plus minus abiraterone. So the triplet in these patients is better. When we look at toxicity at ASCO, we have only seen very short-term toxicity data. Now we have a bit more longer-term toxicity data. It's actually very well tolerated. There was concern that there may be more neutropenia, more fever, febrile neutropenia. The rates are really quite similar. You have to be careful with liver function. So 6% of patients in the triplet arm had grade 3 or more liver dysfunction, transaminase elevation, or hypertension. But for all of the other side effects, they were pretty much similar. And this is the summary. And when you look into more details, the benefit of this triplet therapy was mainly really seen in the high volume patients. In high volume patients, hazard ratio was 0.7, and there was a 19.2 month overall survival benefit, 61 versus 42 months in these patients. In the low volume patients, the hazard ratio is 0.83, and the median was not reached yet. There's no significant benefit at the moment in the low volume patients. And these patients, as I mentioned, were not included. So this was really, piece one really focused on these patients alone. So for the last part, the quality of life data of the VISION trial, because I think VISION is important. We have to get used to using lutetium PSMA in our treatment algorithm. It was really third line or later. Patients had an AR pathway inhibitor. This was mainly abiraterone or enzalutamide. 50% had 2 and 1 or 2 lines of taxanes. Again, 42% had 2 lines of prior taxane treatment. They had a gallium-68 PSMA PET, no relevant PSMA negative lesions, and it was 1 to 2 protocol permitted standard of care or lutetium every 6 weeks, and protocol permitted standard of care. The main results, this is the graphical abstract from the New England Journal publication. I like these graphical abstracts. You see the progression-free survival we have already seen for the control group versus lutetium, and overall survival here as well, a significant improvement, 4 months median overall survival improvement for lutetium versus the control, which was standard of care, which was not a very active control or active treatment for these patients. And at ESMO now, we saw also quality of life data. There were a lot of details and graphs. I just show you the FACT-P, which is a often used tool for quality of life assessment in advanced prostate cancer. Significant improvement in time to worsening for lutetium versus control, and also for pain, worsening of pain significantly better for lutetium compared to standard of care. This is not surprising when we see that lutetium also has a survival benefit, a radiographic progression-free survival benefit, but I think it's reassuring to show that also quality of life is better for that treatment. So I'm already coming to my take-home messages, and I'm almost in time. For locally advanced prostate cancer, the data from STAMPEDE support a more intensive systemic treatment for a limited duration of time, maximum 2 years in these patients. But you have to be careful. Abiraterone is not approved in this indication. We really only have it for the high risk metastatic hormone sensitive patients that we can use it. And in my experience, it's not easy to convince health insurance to support abiraterone in this indication, but the data are really convincing in my opinion. For metastatic hormone sensitive prostate cancer, patients with synchronous high volume disease may benefit from the triplet. I specifically wrote may benefit. I think we have to carefully select patients. It's probably not for everyone because we know docetaxel has side effects and quality of life is impaired. But for young and fit patients, this is definitely for me a new option. And I think the key bottom line in metastatic hormone sensitive prostate cancer is really collaboration between oncology, urology, radiation oncology, all the other disciplines. We have to be able to counsel patients to find the best option that is available in this situation. And for metastatic CRPC, the additional data for vision are reassuring that also quality of life is improved. If you have not heard enough of advanced prostate cancer, please consider coming to Lugano at the end of April for the next Advanced Prostate Cancer Consensus Conference. Many of these topics will be addressed as we did on the 9th of October. There's plenty of questions that we can ask then. And I think with this, we can address questions or go to the cases.
Well, I think, Aurelius, thank you very much for this very comprehensive and clear presentation. So there's quite a bit of practice change. We still have to fight for the Kostengutsprache with, but I think the data are impressive enough. A 9% overall survival benefit after 6 years is really impressive. I mean, are there burning questions? I have 2 at the chat. I think one is coming from Ursula, is very important. In the STAMPEDE trial, in the high-risk localized patients, when should we start ABI and prednisolone concomitant to radiotherapy as soon as possible? Or what is the time frame?
I would start it as soon as possible. I would not wait until, I don't know, 3 or 6 months, but I would start it really quickly. But then again, if you get reimbursement and approval for a specific patient.
Okay. The other question is piece 1. I mean, you mentioned that we haven't seen the radiotherapy data. So basically, I think with piece 1, there are 2 important questions. Do we need radiotherapy? Will, in piece 1, have radiotherapy with a higher dose the same effect as in STAMPEDE? And also the question, do we really need the higher dose, or does the STAMPEDE, the lower dose, of course with lower toxicity, will be that sufficient? What is your take on that?
This is now thin ice because I'm not a radiation oncologist. I hear different opinions. Some colleagues say that biologically, the STAMPEDE dose is quite similar to the 74 grays in 37 fractions, which is the more conventional dosing of radiotherapy. But of course, the STAMPEDE dose is attractive because it's much shorter for patients to go for radiotherapy. So I don't think that dose difference biologically makes a big difference. I would go probably for the more pragmatic one, unless we see convincing data from piece 1 that there is a difference in response. But then we probably also need to see the details then of which patients also had the pelvis irradiated. I asked Karim, he hasn't seen the data, but he thinks that's only a few patients. It's not the majority that had also the pelvic nodes included.
Okay. And the final brief question is, has anyone in the audience tried to get coverage for abiraterone in high-risk localized? I think some of us have. I'm at the present fighting with this with Vertrauensarzt, but we will have some, and given the multitude of insurance companies and given the multitude of Vertrauensärzte, I think we will have a very heterogeneous picture. That's my guess.
The easiest would be to extrapolate the ABI data to ENSA or APA and just say the patient is metastatic, and then you get it without a problem. But that's legally speaking, that's not the PEACE data. We know from the ENSAMET trial that the triplet combination ADT plus docetaxel plus enzalutamide, if you give it concomitantly, has not yet shown an OS benefit, and we hope to see this data at GU ASCO or at main ASCO. This will be important for that.
I mean, the future is probably that we will add some kind of additional anti-hormonal treatment first line in probably most of the indications. But I think for the question of time and considering the time, we move on the cases. You prepared some very good ones, Aurelius.
Yep, let me start with this one, a patient we have seen recently, 74-year-old, newly diagnosed synchronous metastatic. He has, you see on the bone scan, he has multiple bone metastases also in the spine. He has also some enlarged lymph nodes. Prostate cancer, PSA is 120. The Gleason score is 10, 5 + 5. And he has no relevant past medical history. So he's a fit 74-year-old patient. And my question to you is, you can vote now. What is your preferred treatment in this patient in addition to ADT? Would you just give an additional AR pathway inhibitor? And I've combined them as we did for APCCC, ABI, APA, or ENSA. Do you add docetaxel only to ADT for 6 cycles because that's short and intense? Or do you consider the triplet, either analog to PEACE, ADT plus docetaxel plus ABI, or you do it more like Titan and Arches, you give ADT plus docetaxel, and at the end of docetaxel, add APA or ENSA, or do you go for ADT alone? I'm really quite interested in your result or your voting. As often in medicine, there's not one right or wrong. There's multiple options.
So please vote.
Maybe we can have a look at the results. I don't know, do you see? Now we see results. I hope you see that as well. AR pathway inhibitor in addition, 28%. Docetaxel, so the triplet, 50%. Someone voted ADT alone, that's 6%, and some of you abstained, which is also fair if you don't treat these patients or don't make the treatment recommendation. I would say option 1 or 3 are good choices. I'm less convinced for ADT alone in a 74-year-old patient with this presentation, with this Gleason score. My personal opinion is that ADT alone, unless the patient really specifically only wants ADT, is probably not sufficient in 2021 with all the bulk of the data, all the number of trials that we have seen. And I think I will move on to the case number 2, which is a bit more maybe complicated. This gentleman is now 76-year-old. He's newly diagnosed with locally advanced prostate cancer, node positive. PSA is only 7.8. He has a Gleason 8, WHO grade group of 4. He has a relevant past medical history. He has had a minor cerebrovascular insult 4 years ago, and he has a history of multiple sclerosis that was last active in 1990. And of course, now with the new PSMA PET staging option available here, the PSMA PET for staging, you saw intense uptake in the prostate, but you also see multiple lymph node metastases or uptake in lymph nodes suggestive of metastases in the pelvis on both sides up to the bifurcation here. And my question is, I have two questions actually for this case. What is your treatment recommendation? Would you recommend his 76-year-old a radical prostatectomy and try to operate with a lymphadenectomy all the lymph nodes that have shown to be positive on the PET? Would you go for radiotherapy of the prostate plus the pelvis plus systemic therapy? We will discuss systemic therapy later. Or would you go for systemic therapy alone or abstain?
Again, please vote now.
This is a question, I guess, for the MDT or the tumor board. This is hopefully not something that you have to decide on your own. Of course, patient factors are also important. The past medical history here is important. But again, it's not just one right or wrong. Can we maybe see the results of this vote as well? Okay, so no one voted for radical prostatectomy. I suspect there's very few urologists at the moment online. The majority voted for radiotherapy plus systemic therapy, and a quarter voted for systemic treatment alone. In my opinion, my humble opinion, you can disagree. I think systemic treatment alone is probably, again, not enough. I mean, by all the criteria of STAMPEDE, of HORAD, he's a low volume, he's locally advanced, and there is a benefit of local treatment with, in these trials, radiotherapy. You could use even the STAMPEDE radiotherapy dose of, although most of the STAMPEDE patients had bone metastases, only very few were patients with only lymph node metastases, and they have a better prognosis. So I guess local control is really important. And then you get into the details with the radiotherapist of which dose is needed. Is it a more conventional, or could it still be just the STAMPEDE radiotherapy dose? And let's go to the second question, which is about systemic treatment. If you voted for systemic treatment with radiotherapy or systemic treatment alone, would you go for ADT for 2 to 3 years? Would you go for lifelong ADT because he has lymph node metastases? Would you consider ADT plus an AR pathway inhibitor? I suggest abiraterone based on the STAMPEDE data, but limit the ABI for 2 years, or you can also abstain. This is a tricky question, I think, for us oncologists, because so far we have not really been much involved in the treatment decisions for these patients. But in the future, more and more, we will have to, because as Jörg said, these new endocrine agents move earlier and earlier into the disease history and spectrum of prostate cancer. Let's maybe see what we have here. The majority by APCC standards, not a consensus. You all are convinced by the STAMPEDE data that at limited duration, 2 years of ABI is a good choice. Some voted for lifelong ADT. Others voted for ADT for 2 to 3 years. It's a tricky question. I guess if you go for radiotherapy and additional systemic treatment, especially also the 2 years of ABI, in my opinion, the beauty of that more intense treatment concept is that you then stop the systemic treatment and wait and see what happens. The testosterone eventually will recover. Probably PSA at some point will also rise again, but some patients probably may have very good local and long-lasting control and don't need a lifelong ADT with all the associated complications that come with longer treatment duration. I have 1 more minute. Jörg, you're the moderator. I don't know whether there are any burning questions in the chat that we should address.
No, it's just a comment which I have to mention within applause, because there are 16 urologists listening here at the Inselspital. The presentation is transferred to the meeting room, the team room there. So it's 16 urologists, they don't vote, but they're listening and they're
booing the voting results with no one voting for surgery.
Yeah. Okay. Well, we can't hear them because they are muted. but they will listen to us, and probably with your case, most of us would agree for radiotherapy in such a locally advanced and also not a very young. My question would be, in this last case, would you also go for radiotherapy plus ADT if this was a 55 or 58-year-old man? You consider much younger.
Excellent question. I think it really, if you go for surgery, you have to discuss with the patients that it's probably a multimodality approach. The risk is that not all the lymph nodes can be removed, that there may still be a persistent PSA, and when you do a repeat PSMA PET, you still find some activity, and then he still qualifies for ADT and 2 years of ABI. I guess it is an option that needs to be discussed, and I think that's why we need to discuss the options, surgical and radiotherapy, from both angles with these patients, especially if they're younger, in my opinion.
Because in young patient, you can still say, okay, your resection and a radical prostatectomy saves you time. You still have time later on for radiotherapy and the entire systemic treatment, but you can delay it, and so you can gain time by doing an upfront radical prostatectomy. I think that's a strong argument in young patients. And
not everything that is positive on PSMA PET is necessarily a lymph node metastasis. We have to be careful with that. So if you do surgery, the beauty of the surgical concept is that 6 weeks after surgery, you know by PSA whether you removed everything, whether you had a very good local control, or whether there's still persistent tumor somewhere.
So in a 58-year-old man, I would strongly consider surgery, having all the options later on. But in a 76-year-old man, I strongly, entirely agree with you. Okay, there come 2 more chat questions before we move on. This patient, it's come from a radio-oncologist, Alessandros. This patient will recur within less than 1 year with surgery alone without any adjuvant treatment. Yes, you're right, but well, we might have gained 1 year. And also there's an argument of Aurelius, but I entirely agree. I think these options have to be discussed, and surgery would only be something in the younger patient. But entirely agree with Alessandros. Patient who is so far advanced to so much high risk localized probably will relapse after surgery rather sooner than later. Aurelius, thank you very much indeed. It was an excellent presentation, very nice cases. And we move on to Ursula Vogel, to Lugano or Bellinzona on renal cell cancer. Ursula, thank you very much. Thank you very much for joining us.
Thank you, Jörg. Actually, I'm in Locarno at this moment, but I'm flexible, somewhere in Ticino, and I'm happy that also colleagues from Ticino are connected. Thanks to the organizers, we do it in English, so we're open for all regions of Switzerland. And I will present you today the highlights of renal cell cancer of this year's ESMO. These are my conflicts of interest. So I will briefly present you 4 abstracts. One abstract that is actually something that an update with patient-reported outcomes from the Keynote 564 study that has been presented already at this year's ASCO meeting with pembrolizumab versus placebo as adjuvant therapy for patients with renal cell carcinoma. The second abstract is the STAR trial, which is a study from the UK, a phase 2/3 trial, actually from treatments that seems to up today a little bit outdated, with TKI monotherapy with sunitinib or pazopanib, but was still using them, and they were adding or wanted to try to answer the questions if treatment breaks are feasible. Another study with was the Prism trial with nivolumab in combination with alternatively scheduled ipilimumab. So we'll show later how they implemented the ipilimumab to the standard schedule. And last but not least, a final slide of the update from the first immunotherapy combination approved in first-line treatment from nivolumab and ipilimumab from the CheckMate 214 versus sunitinib 5-year follow-up. So the objectives of our presentations are, of course, discussion on their potential impact on practice change in daily clinical practice. So this is the first trial, pembrolizumab adjuvant. And here you can see the study design again, just a short reminder what they presented at the ESMO meeting. So patients after nephrectomy within 12 weeks prior to randomization with no prior systemic therapy, good performance status, with clear cell renal cell carcinoma, receive pembrolizumab 200 milligrams flat dose every 3 weeks for about 1 year versus placebo. Were randomized and also stratified into different subgroups. So there was also a stratification between M0 and M1 that were resected of metastases. Primary endpoint was disease-free survival by investigator. The trial reached its primary endpoint, disease-free survival by investigator, with a highly significant p-level. This trial was positive. Concerning disease-free survival. This is the reported quality of life outcome presentation. So they reported 3 different questionnaires. And as you can see on the bars, there was no significant difference in deterioration of clinical performance status, physical functioning, or other questions. The discussant at the ESMO meeting, Brian Reaney, actually said that it's of course difficult to create quality of life questionnaires in the adjuvant setting, since patients don't have symptoms from their disease because they're actually disease-free after resection. But still, they are encouraging data, so there was no clinically meaningful difference in health-related quality of life or symptom scores in the adjuvant setting with pembrolizumab. So the scores remained stable over the reported study period. And as I mentioned, disease-related symptoms are rarely severe at this disease stage, so we have to be cautious with those questionnaires. The second abstract I'm presenting is the STAR trial, comparing temporary cessation with allowing continuation for TKIs in first line with sunitinib or pazopanib in locally advanced or metastatic renal cell cancer. As you know, we use those drugs for more than 15 years. Actually, 15 years ago, sunitinib has been approved. So we have a lot of experience with those drugs. And as you know, these treatments, you can actually play with those TKIs. So the approved schedule of 4 weeks on and 2 weeks off, we have actually adapted in daily clinical practice. So most of clinicians use 2 weeks on, 1 week off already, or did implement treatment breaks due to the necessarily upcoming adverse event like diarrhea. So there were patients maybe also taking 1 week treatment and doing 2 days off. So the protocol, actually the design of the trial was that the control group continued treatment until disease progression. And the interventional arm actually was allowed to have treatment breaks. There was a minimum number of treatment breaks that they have actually to fulfill. Here you see that how many breaks did the participants start. You see from most patients had at least 1 treatment break, but up to 3 or maximum of 9 treatment breaks. And the overall outcomes, so primary objectives, were overall survival, quality adjusted life years, so the QALYs, which is also a very attractive endpoint, and other endpoints that have been reported only briefly. So this is the overall survival analysis. This, of course, the statistics and the model a bit complicated, but what we can see is actually that patients that received treatment breaks had no inferior outcome in the intention to treat population for different endpoints when they actually had treatment breaks. So this is the cessation arm, and the other ones that didn't have any treatment breaks. So you see that those curves actually overlap. So the problem, of course, with that trial is that we don't know exactly how many treatment breaks they had. So about the length of treatment breaks would be interesting. And actually, how did they respond after the re-challenge when they were needed? We know from our daily clinical experience that patients respond to a re-challenge to a TKI, also from dose modifications or dose re-escalations. We know that they can respond. And these data are not really anymore up to date, because we know that TKI monotherapy now in first line we use in only very selected patients with favorable risk, maybe because current guidelines actually do not implement any more TKI monotherapy as a standard option for everybody. As you can see here from the updated guidelines, MRCC, we have only combinations for all risk groups as standard of care. And the question is also, this trial is very interesting, but can we actually use these informations also now in the IO-TKI combinations? This is not yet clear, and trial designs that implement that questions are urgently needed, because of course TKI long-term toxicity and also the management of TKIs is not easy, although we have a lot of experience now with those drugs. One other point is, of course, that those treatment breaks in the study showed that have been not only beneficial because they didn't show any difference in overall survival, but of course also they have been shown significant cost savings with those treatment breaks. Another interesting trial was the Prism trial, so nivolumab in combination with an alternatively scheduled ipilimumab in first-line treatment of patients with advanced renal cell carcinoma. We now have long-term experience with the combination of ipilimumab and nivolumab, but you all know also from the Checkmate 214 trial, initially presented at ESMO many years ago, actually showed that 47% of patients experienced a grade 3 or 4 treatment-related adverse event, and also that almost a quarter of patients discontinued due to treatment-related adverse event. That doesn't mean that they don't benefit after cessation of treatment, or did benefit. So we know that they're long-term responders, mostly also those that had high-grade toxicity, but still we want to have an approach, or in the future allow the patients to have less toxicity from those very efficient drugs. So we know that the CTLA-4 blockade, so ipilimumab, seems to be related to more intensive toxicity. This is dose and also time dependent, and you see that some organs might be more involved from the combination of ipilimumab or nivolumab together instead of nivolumab in monotherapy. For example, the liver toxicity and also the skin toxicity seems to be a little bit more from the combination. Also the renal toxicity that usually comes a little bit later in the course of treatment. And these days, we know from a trial in non-small cell lung cancer that it might be beneficial, it's better tolerated at least if ipilimumab is given in a different dose schedule, so not every 2 weeks as in every 3 weeks in the beginning, but every 12 weeks actually the second dose of ipilimumab. And this was the rationale for this trial. This is the study design of Prism. So the modified ipilimumab is the same dose, but patients receive ipilimumab at the beginning and then after 12 weeks. This is the usual standard of care that we use. The primary endpoint was the proportion of patients experience at least one treatment-related adverse event of grade 3 or 4 within 12 months of initiating therapy, which is a very interesting endpoint. So these are the results from the primary endpoint. So you can see that the modified ipilimumab actually showed a significantly lower percentage of patients receiving high-grade or experiencing high-grade toxicity, with 32% instead of 53% of patients with the standard ipilimumab nivolumab schedule. Actually, the type of adverse event was also a little bit different. So you see that the modified ipilimumab did give a little bit less liver toxicity, and also in concerns of really that things that we really fear because they are severe and can be fatal. Actually, also the hypophysitis was a little bit was less common in patients with the modified ipilimumab schedule. So these are encouraging data. These are the secondary endpoints. As you can see, those curves overlap, although of course these are really, this had not been the primary endpoint, so this is only hypothesis generating, but you see that obviously the doses that are missing from ipilimumab do not give harm to response of patients. So you see that the overall response rate that they reported was actually almost as the one from the standard ipilimumab nivolumab schedule. So giving ipilimumab 12 weekly instead of 3 weekly led to a significant reduction in the proportion of patients experiencing grade 3 or 4 treatment-related events. This is a positive phase 2 trial. I think further investigation in larger trials is needed. It's not yet applicable in clinical practice. And I would be happy if other trials ongoing look for alternative schedules. We already have one ongoing in Switzerland. So the SAKK 1770 study already reported data at ESMO last year. So Switzerland has already been innovative, asking those questions of alternative schedules. And to summarize the highlights, I think I would like to close with a very encouraging presentation of the 5-year follow-up of CheckMate 2114. This abstract actually underlines the great steps we've made forward in renal cell cancer. I remember 15 years back when I started with MRCC, the prognosis of those patients was really bad. So you see the overall survival data of 5 years now with a median OS of 47 months versus 26 for sunitinib. So we have a 5-year survival here of 43%, and this is only the intermediate poor risk population. So we can assume that patients, and they showed the data, although not applicable in clinical practice because we don't use ipi-evo in the favorable risk population, but actually we have now a 5-year overall survival rate of MRCC of over 40%, and some patients even 60%, depending on the risk group. And in the last 15 years, the 5-year overall survival rates improved from 15 to 20%. So they doubled actually, or tripled in some risk groups. And there was also another analysis shown that, of course, the best overall response, or that actually the probability of living of 2 more years when patients initially responded with a complete response is very high. So you see, once a complete response has been achieved, within the first 3 years, there's a high probability that patients remain in complete remission. And this is, of course, I would not use the word cured because we can't assure the patient curance, but it's very encouraging that that trend goes for a while or for even years in those patients. So practice changing in MRCC after ESMO 2021, I think there was nothing striking, nothing like Aurelius was able to show us in prostate cancer, but I think we're moving. So pembrolizumab as adjuvant treatment in intermediate high-risk RCC patients is implemented in the 2021 ESMO guidelines, although not yet approved, and has shown a beneficial quality of life data. Alternative schedules, TKI-IO and IO-IO have been presented. So ipilimumab 12 weekly plus nivolumab needs to be further explored. I think it's affirming in cases where we have to suspend ipilimumab because there has been toxicity, for example. This is not yet practice changing, and drug holidays from TKIs are clinically feasible without risking progression in selected patients. But it is not clear if it applies today to the IO-TKI combination era. Thank you very much. So I'm open if there's some burning questions at the moment, and then we go on with the case presentation.
Susanna, thank you very much for this comprehensive review. There are 2 questions from Aurelius and perhaps 1 remark from my side. First, I use my position as 1 remark with the favorable risk patients. You mentioned that all the guidelines recommend to use an IO plus TKI combination. Actually, this surprises me a lot because we have 5 trials out. None of them have shown an overall survival benefit compared to TKI alone. And 1 trial, actually, the CheckMate 214 trial, actually showed that the combination of double immunocheckpoint inhibition was worse than the TKI. So we had a big debate in the background and on ESMO whether to use TKI in favorable risk patients. Still, that's my practice. Those patients are rare, admittedly, it's 10 to 15%, it's not many. But given that they have a long-term survival of 3, 4, 5 years, still have the options. That's just my comment on the favorable risk patients. But all the others, as you said, it's super that we have the combination treatment of TKI. It would be very interesting if the STAR trial can be extrapolated to the TKI IO combination, so we can get rid of the TKI in the combination after, say, a couple of months, and in patients especially who responded. So Aurelius had 2 questions. One, would you consider EP12 weekly already in your patients tomorrow?
I think if patients actually don't show high-grade toxicity, we should keep up with the standard schedule, because we don't know yet actually, and these are small numbers, if there are patients that might need a second dose or a third dose of ipilimumab. So in daily clinical practice, no, I will go on with the regular schedule. But I think, as I mentioned, it's affirming if we have to suspend the ipilimumab after the first dose, for example, for toxicity, and then consider ongoing only with nivolumab, that we don't actually harm the patients.
Okay. Right. The other question is also tricky, also coming from Aurelius. If you have a patient who had adjuvant pembrolizumab for 1 year and he relapses after 6 months, what do you do?
Well, I think this is generally a question with all the adjuvant treatments that are coming up. We as oncologists always have our cutoffs of re-challenge, like with platinum-based chemotherapy, that we say 6 months might be a cutoff that we can reuse the drug. So I would probably go for depending on the tumor volume load, on the sites of metastasis, all the backgrounds and prognosis of patients, but I would probably assume we could also go for a TKI IO combination as a re-challenge, but this is too early to say. And I would be keen on seeing the follow-up data of the adjuvant trial, what actually treatments they received after relapse, but this is too early because unfortunately, or luckily, patients don't relapse so easily or so early.
And that's also leads to the question of Anya. It's actually, can we consider with the data given and a rather small improvement, there isn't statistically significant, but it's not that impressive like in prostate cancer. Can we really consider adjuvant pembrolizumab as a new standard today? I think at ESMO, the committee discussion said yes, but they always do. But if you see a patient tomorrow with intermediate or high risk, would you go for adjuvant pembrolizumab as a new standard already?
I would definitely explain the patient that we don't have overall survival data. So I'm also very critical and like to see also overall survival data before telling the patient this is really a standard of care. Disease-free survival has been shown in other diseases and tumors that it's a valid endpoint, but still overall survival is important, since we don't know what actually patients experience after that 1 year of immunotherapy as potential side effects, because we have actually also side effects after finishing the treatment, so they can be upcoming. I think it's an individual patient selection depending on the risk. I will show you later in the case presentation the guidelines that were actually very positive for implementing pembro as a new standard in adjuvant treatment. I see this actually very critical to make it open for everyone as obligatory. So
if you have a 10% improvement, so you treat 90% unnecessarily, that's a problem.
Yes.
In the adjuvant setting. But let's move to your questions. You have to your cases. You have exciting cases. We're looking forward to that.
So I'm presenting you a 71-year-old man with a quite short medical history of hypertension, no surgical history, and he's using only one antihypertensive drug. He presented in the emergency department with weakness, fatigue, dyspnea, and fever. And the CT scan showed this renal mass, but don't look only at the kidneys in that case. What's coming here, this is a large tumor thrombus that's actually going up to the thorax into the heart. So really extensive, locally advanced disease. And our surgeons were kind of very motivated to do surgery on that patient, since there was no M1 disease present in the staging. And actually living with that tumor thrombus is also not nice, giving him a risk that that tumor thrombus actually evades or enlarges. So this patient was fit to have right radical nephrectomy, local regional lymph node dissection, also a cable thrombectomy with an extracorporeal circulation needed, and a lot of interdisciplinary surgeons on site. The histology report showed a clear cell renal cell carcinoma with rhabdoid features, PT3C, PN1, and a G4 tumor, which is automatically with sarcomoid or rhabdoid features, presents as a G4 tumor. So what post-nephrectomy treatment would you recommend to this patient? Clear cell RCC, we have the question to vote to come up. There you can see the answers. So again, a 71-year-old patient, ECOG 0 with these histological features. Would you go for a follow-up, adjuvant treatment with 1 year of sunitinib, adjuvant treatment with 1 year of pembrolizumab, first-line palliative treatment because you think it's already metastatic disease, or enrollment in a clinical trial? You can vote now. Okay, so you're convinced that this patient should receive pembrolizumab, so not a consensus, but 65%. So I think actually these are the most, it's clear that follow-up for that patient, maybe with the data we have from pembrolizumab, is okay. It's actually the standard of care because pembrolizumab is not approved yet as adjuvant. When you look at the guidelines, you would go for pembrolizumab. Definitely no 1 year of TKI because sunitinib has shown only disease-free survival beneficial data, only approved by the FDA, never approved by us. And it's really the quality of life has not been good with sunitinib, so no standard. He's not palliative because actually at this moment he was M0. And of course, enrollment in a clinical trial, if available, is always the best choice. I think in this case, you should discuss with the patient with the benefit of disease-free survival and the quality of life data, since he has high-risk clear cell RCC, but we have to inform the patient that treatment is still off-label. And what we should maybe do is to restage the patient before initiating pembrolizumab to exclude a progression to M1. And the trial actually included patients within 12 weeks after nephrectomy. I'm a little bit, I was concerned in that case with that extensive locally advanced disease that the patient might have developed after surgery already, metastasis. So when you look at the disease risk categories from the keynote trial, you see that that patient definitely enters the high risk category with PT3C, G4, and PN1, and also the the rhabdoid features that make him really at high risk. Again, the data from ASCO and ESMO for the argument for pembrolizumab. And as you can see here, the updated RCC guidelines, you see that adjuvant pembrolizumab should be considered optional for patients with intermediate or high-risk operable clear cell RCC after careful patient counseling regarding the immature OS. So they actually wrote it in very detailed that patient has to be informed about the current data landscape and that the treatment should start within 12 weeks of surgery and continue for up to 1 year. There's also been a note on the M1 NED population. As you can remember from the presentation, they show the forest plot of the pre-stratified group with the M1 no evidence of disease population. So they had a synchronous metastases that have been resected or within a certain time frame. And there you can see the forest plot that favors pembrolizumab. But look at the numbers. There have been 26 patients and 58 patients, a super small patient population with the M1 NED. So actually they gave a strong recommendation with 1A for the M1 NED population as so-called pseudoadjuvant treatment for pembrolizumab. This was kind of surprising to me. But in the actually they added also a comment to the metastasectomy as an alternative to the systemic treatment, and actually say you should not go for metastasectomy if the patient relapses actually within a short time frame of nephrectomy, but go for a systemic surgery, systemic treatment. Well, I was cautious and I actually did a restaging baseline prior to discussion for the adjuvant treatment 6 weeks after nephrectomy. And as you can see, the patient presents already with a single pulmonary lesion of 2.5 versus 3 centimeters of the right medial lobe. And when you look at the risk of his recurrence from the Library score, his score was 9. And you look at that curve with patients with a score over 8. So actually patients relapse, the majority, 50% within 6 months. So it was most likely that that patient relapses and has already metastatic disease. So this was the surgical intervention he received, and this is the CT scan. So the next question that I would like to pose now is, what do you do now in this actual situation? He's now M1, no more M0, oligometastatic, single lung lesion within 6 weeks after nephrectomy. He's an intermediate risk with 2 points, 71 years old, now an ECOG 1 after extensive surgery. Would you wait and see and repeat the CT in 2 months because he has a single small lung lesion, surgical resection of the single lung metastasis, palliative first-line treatment with ipilimumab and nivolumab, or would you go for a first-line palliative treatment with one of the approved IO-TKI combinations? You can vote now. Let's see if there are other motivated surgeons to resect also this lung metastasis. Well, they are. Wait and see strategy, okay, and then go for systemic treatment. Interesting. Actually, the guidelines in early oligoprogressive disease say you should not go for that, but rather for systemic treatment. I think that this patient, in my opinion, look for that very aggressive disease with rhabdoid features, resection of the single lung metastasis. I mean, you don't know, I've seen that patient and I know him now, he wouldn't be able to do another surgery looking at that really heavy intervention he had a few weeks ago. So he wouldn't be fit for do another opening of his chest or do, it's not even possible to do a wedge resection. Wait and see also for that rhabdoid fusion is an option. We know for small oligometastatic disease in renal cell cancer, it can be allowed to do wait and see strategy, but I think that histology is really aggressive. I would rather go for an IO or IO-TKI combination, as we know that the sarcomatoid or rhabdoid features respond well or better to a component of immuno-oncology drugs. Thank you very much, and I'm open for questions for discussing the cases.
So thank you very much for those nice cases. I think very instructive. I think most of us would probably not have gone nowadays for first-line surgery, but would have treated him first and perhaps go then for surgery. But I think for the matter of time, we have to move on now to bladder cancer. It was a very interesting presentation. I think we could go on with discussion, but I think Anja Leuchert's also data to show on bladder cancer. Ursula, thank you very much. And hello, Anja, thanks for joining.
Hello to everyone and good evening, and thank you very much. It's my pleasure to be part of the ESMO exchange tonight and present you the highlights of bladder cancer. Are you able to see my slides? That would be my question first. Is that working?
Not yet, Anja.
Not yet, so. I try again.
Now we're seeing your slide. Maybe you go to the presentation mode.
Yes. Now it should
Thank
work.
you.
So
Perfect.
great. Yes, the last speaker tonight. Here are my disclosures right before I start with my presentation of 2 abstracts. The first one in localized bladder cancer, the PhasPA trial, phase 3 trial, and the second one in patients with metastatic disease upfront and cisplatin ineligible. It is here a phase 2 trial. So I'd like to start with the first one, a really interesting one, really great, performed by the French. The GETUC group is really impressive. They are really able to perform those trials, and it's great to have the results here. It was presented by Christian Pfister, and the title was dose-dense MVAC or gemcitabine and cisplatin as perioperative chemotherapy for patients with muscle-invasive bladder cancer. So what is the background? In localized disease T2 to T4N0 M0, radical cystectomy plus pelvic lymph adenectomy is still the standard of care, yes, but more than 50% of the patients nevertheless will die because of metastatic disease. And the problem here, we all know that there are often already lymph node metastases, even if it's not shown in the CT scanning. So the first choice in these localized patients is neoadjuvant cisplatin-based chemotherapy. In all guidelines, you see international, this is recommended as first choice in this population. And 2 regimens frequently are used, the cisplatin or the dose-dense MVAC. In former days, we had the MVAC. In newer days, we have the dose-dense every 2 weeks with GCSF support MVAC. And the absolute survival benefit is in the trials 5 to 9% with the neoadjuvant chemotherapy. We have pathological complete remission rates after cystectomy of about 25 to 30%. But the problem, a lot of eligible patients, and you have to have a good renal function to be able to get neoadjuvant chemotherapy. But even these patients eligible for that still do not receive neoadjuvant treatment. The study's design here in the PhasPA trial, the patient population we discussed here was the localized disease, good performance status, and all criteria for cisplatin eligibility be there, good renal function as the major criteria. And they had been randomized in the standard arm with 4 cycles of gemcitabine cisplatin versus the here experimental arm with 6 cycles of dose-dense MVAC. And after that, patients went on to cystectomy, or they got the treatment as adjuvant treatment. You see 493 patients could be analyzed. 88% were neoadjuvant patients. The rest, 12%, were patients who got the treatment as adjuvant treatment. The primary endpoint was PFS at 3 years. Inclusion criteria, you had to have pure or mixed urothelial bladder cancer, no neuroendocrine components inside. This is kind of important. And you see the regimen with the gem-cis and the dose-dense MVAC below in the slide. Here are the results, and as you can see, for progression-free survival, it was positive, or it was better for the dose-dense MVAC patients with a hazard ratio of 0.77 compared to 4 cycles of cisplatin and gemcitabine. This was for the whole group, including neoadjuvant and adjuvant patients. And here you see the results for the only neoadjuvant patients with a hazard ratio of 0.70, also in favor for the dose-dense MVAC. If we go for the pathological complete remission rate, you have slightly better outcome with the dose dense also here in comparison to the gemcitabine cisplatin group. Time to progression, also you can see it better in the dose dense MVAC arm. Overall survival data are not mature yet, but the trend shows also superior results for the dose-dense MVAC group compared to the gem-cis group. The final data, the presenter said, are expected to confirm these results, but of course we have to wait until we see those data. Then for future trials, it will be maybe another standard arm as a comparator, because in all trials now going on with IO and everything else, the comparator now is always the gem-cis arm. But we have to see what happens really when we see the overall data, which will come within the next years. I guess it will not take too long to get those data also. If we have a look, a more close look to the group that got neoadjuvant chemotherapy and then radical cystectomy, you can see here the majority of patients could get the surgery. Over 90% or 90% in both arms. But you have to mention also that only 2/3 of the patients received the planned 6 cycles of the dose-dense MVAC instead, but 84% received all cycles of the gem-cis. So you can see it was more or less a toxic treatment compared to the standard arm. Delay of surgery, also mentioned, was kind of the same in both groups. Yeah, it is important how the side effects are, because you have to be fit to get the surgery afterwards, relative in a short time after finishing the chemotherapy. And on the right side, you see the listing of the well-known chemotherapy side effects like nausea, also diarrhea. You also see chemotherapy-related death, 2 more in the dose-dense MVAC arm compared to 1 in the gem-cis arm. What was presented by the discussant at ESMO was how do the results fit in other trials. And as you can see, if you use the 4 cycles of gem-cis in the SWOG trial, even similar results with the complete remission rates. What is more or less better in the dose-dense MVAC arm here with 6 cycles is higher, the proportion with the T0 N0 afterwards compared to the other trials, but it does not differ much. And what will be interesting, how will the FESPO data compare with the novel neoadjuvant trials with chemotherapy and IO? And as I mentioned, here we always have the comparator as gemcitabine cisplatin and not the dose-dense MVAC. For me, it is a practice-changing study, but I think it is not feasible for all patients eligible for neoadjuvant chemotherapy. It is a toxic treatment to give 6 cycles of the dose-dense regimen, and you could see that only 60% received all planned cycles, whereas 84% received all planned cycles in the GemCis arm. The delay of surgery, I think this was quite feasible. And what was the good news, 90% of all patients could get their surgery finally. We have no results so far for IO plus chemotherapy data, and this will be interesting for the future. And I guess there will be new results changing the standard treatment, probably in the neoadjuvant or also adjuvant setting. Most important for me is to offer neoadjuvant or perioperative chemotherapy to patients being fit to get it, and here especially the neoadjuvant treatment. So also we heard it with the prostate, we have to present the patients interdisciplinary to discuss if the patient is a candidate for neoadjuvant chemotherapy before going to surgery. The next presentation was a phase 2 trial in the metastatic setting of bladder cancer, and here you see the treatment landscape of all the possibilities we now have in metastatic disease. Upfront first-line platinum-based chemotherapy, cisplatin or carboplatin, but we have the group of patients not being fit enough for any of the treatment with cis or carboplatin, the so-called platinum ineligible patients, and we can offer them a monotherapy with immunotherapy. For the further treatment lines, you see the option, you know, if you respond to first-line chemotherapy, at least with stable disease, maintenance with avelumab is the new standard of care, and you see also new combos coming up, the enfortumab vedotin as second or third line, as well as sacituzumab govitecan, both still not FDA approved, as well as the FGFR inhibitors in later lines if you have mutations or fusions. And here the most common used for bladder cancer is the erdafitinib. The NORTH phase 2 trial was presented by Tom Powells. Patients were ineligible for cisplatin, had metastatic disease, no prior systemic therapy for metastatic bladder cancer. They had been randomized 1-to-1 into the arm erdafitinib mono and erdafitinib plus immunotherapy, selected by FGFR mutations or fusions, not selected if PD-L1 status was positive or negative. The primary endpoint here was overall response rate. 90 patients had been enrolled in the trial. There are other trials ongoing, the FORT2 trial, the FIGHT-205 trial with other FGFR antibodies, and here we have some results of monotherapy with erdafitinib, an overall response rate of 40% given as monotherapy, less with the others. So the rationale here for the combination was to get increased efficacy, to overcome resistance, to address the heterogeneity in this patient population, and also to target the microenvironment. Here are the results. Here you see the baseline demographics. A problem was that in a huge part, the PD-L1 status was unknown. And here you see most patients had mutations, less patients had only fusions. And here you see the overall response rate for the combination, higher with 68% compared to 33% in the mono arm. Not many complete responses, slightly higher complete responses in the combination arm. And to go to toxicity, what was already known, giving FGFR inhibition and IO therapy, similar safety profiles in each arm, independent if you got the combination or the mono therapy, and also consistent with a toxicity reporting in other trials, in the phase 1 trial here and in the 4.2 trial. Eye toxicity and hypophosphatemia, we all know that, was the most common toxicity. That the toxicity is higher with the combination. We have more discontinuation rates in the combination arm. Is this trial practice changing? No, it isn't, because it is small numbers. We don't have any results concerning PFS or OS, but what we can say, it's promising. The combo appears to be more effective in this patient population, and maybe this is another option for patients not being fit enough to get chemotherapy, even if you have to keep in mind that you have also toxicity with FGFR and the combination FGFR and IO. They saw responses in both FGFR mutation and fusions, and they saw responses also in patients with low or no PD-L1 positive status. And with this, I am happy to take questions before we go to two poll questions. And yes, let's see what is in the chat. Thank you very much.
Anja, thank you very much for your presentation. I think it was an excellent overview, especially on the VESPER trial, which is practice changing also to my view in a fit patient. If it comes to Daphne, I would be great to have all these options first line. It's wonderful if you have those drugs. I would be even more enthralled if the price of those drugs would also come down to the price of cisplatin, which we use for first line now. But that's just some kind of cynical remark. We do have those first line options, but they come under price. Now, I see no questions in the chat, so I think for the sake of time, we move on to your cases. I know you have prepared two excellent cases, and we're going to see them. Thank you very much, Anja. Let's come to the cases.
Yeah, let's come to the cases. And this is the first one. It's a 71-year-old gentleman newly diagnosed with localized bladder cancer, lymph nodes described in the CT scan with 12 millimeter in diameter, but not suspect for lymph node metastasis. He has a smoking history, relatively good echo performance status, a kind of good renal function with a GFR of over 60 and no relevant comorbidities. And now here comes the question: what would be your preferred treatment option for these patients? Would you go for adjuvant chemotherapy here in case he has a T3 or 4, or even if he has a lymph node positive disease? Or would you only go for surgery and do not give any perioperative chemotherapy? or would you discuss the neoadjuvant cisplatin gemcitabine 4 cycles, then followed by surgery? Or would you go for the neoadjuvant dose-dense MVAC 6 cycles followed by surgery, now knowing the new data? Or would you abstain and ask in your board? Please vote now. I think we can have the results. So here you see everyone would give neoadjuvant chemotherapy. I think that is great to know that in Switzerland this is really performed. In other countries it is not standard of care. Unfortunately, a lot of patients do not get neoadjuvant chemotherapy and go straight away to operation. But here it's a fit patient, and I also would agree to the majority that this is a patient because of the new data, that this patient can try to get the 6 cycles of dose-dense MVAC. I think the results are really convincing, even we don't have the overall survival data yet. And I would agree, and I would try to give dose-dense MVAC, which is new for me because I used to give the cisplatin gemcitabine. I'm not so familiar with the dose-dense MVAC, but this is what I change in my daily practice. In fit patients, I switch to this regimen with 6 cycles of dose-dense MVAC. So we go to the next case. This is a younger patient, 62 years old. He has a newly diagnosed synchronous metastatic bladder cancer with lymph node metastasis, also smoking history, also a good ECOG performance status, a little bit reduced renal function with a GFR under 60. He had a myocardial infarction 5 years ago, but the ejection fraction is quite well, and the ultrasound was 52%, and he's PD-L1 highly positive. So what would you recommend for your patient or for this patient? First choice, give him 4 to 6 cycles of Gem-Cis and then avelumab maintenance if he will have stable disease or better. Would you go for first-line immunotherapy mono? Would you give a combination of chemotherapy and IO upfront? Would you go for chemotherapy not with cisplatin but with gem-carbo and then give maintenance with avelumab if stable disease or better is reached? Or would you go for 6 cycles of platinum-based chemotherapy and then only follow up the patient, or would you abstain? So please vote. So I think now we can have the results. The majority here would go for the standard of care in platinum eligible patients. Give the patient 4 to 6 cycles of Gem-Cis or Gem-Carbo. I think this is a kind of something I would also try the Gem-Cis because the renal function isn't really bad. I mean, it's a little bit under the 60. I would try to make to get an optimal renal function by telling him to have enough fluids and stuff to optimize this this GFR. But then I also would give him the Gem-Cis, and if he has stable disease or better, yes, this is the new standard. I would talk about avelumab maintenance. I think also the carboplatin is quite fair because I didn't see the data yet, but there is a subgroup analysis looking if carbo or cisgem with the avelumab maybe are equal. So the question in the future is, can we tell the patient we don't need the cisplatin because more side effects, acute toxicity, and can we also use the carbo gem with the same efficacy if giving avelumab as maintenance? I would not go for the combination with IO upfront because the data did not show any survival benefit in several trials. 3 trials had been presented over the last years, and none of them showed overall survival benefit. Also, with the avelumab data, if the patient has contraindication for the immunotherapy, yes, but if he is fit and wants to get standard treatment, I would not only give him the 6 cycles of chemotherapy. As well as first-line immunotherapy, if you have unfit patients, yes. If they have a PD-L1 positive status, yes. But this is only if a patient cannot get any chemotherapy at all, in my opinion. With this, I thank you very much. And maybe there are some questions left I can answer. So I would give the word to Jörg for a moment.
Anja, thank you very much for the cases. It was great. We're a little bit over time, but I think we still take the time because there's to answer some of the discussions that are vividly taking place in the chat. So number 1 is relevant question. So it's the Swiss approach of dose dense MVAC was 4 cycles with GCSF. So shall we stick to the Swiss approach and give 4 cycles of dose dense MVAC, or should we really adhere with the concept of the VESPER trial and go for, and aim for 6 cycles? That's number 1.
Yeah.
Addition question. Also, the cis 70 milligram cisplatin is also some kind of a heavy attack on the kidney. So many of us rather go for a split dose cisplatin, either day 1 or 2 or day 1 and 8. So those are 2 questions this being discussed in the chat. What's your take on that?
I would adhere to the trial design and try in a fit patient to give him the 6 cycles of the dose dense MVAC. But you saw only 2/3 got it finally. The rest got only 4 cycles. So this means it is kind of toxic, and therefore it's not for everyone. But if I would have a fit patient, I would try to give him exactly what was given here in the trial, because the results are convincing, and all patients, even with the 6 cycles, 90% of patients could go for surgery in a quite short time after having finished chemotherapy. So 6 cycles of dose dense MVAC if possible. The split dosing, I do that with the GemCis. I also give the 70 milligram at day 1. It depends how the patient sits in front of me. There are patients with this marginal GFRs, if the renal function is around 60, or like in the case 58, 55, I give neoadjuvant treatment, but then I go for the split dose because it's better tolerable. Also, with nausea in metastatic disease patients getting cisplatin, I often do it the same way because I used to give the GemCis, and in my daily clinical practice, 60% get the day 1 cisplatin, the rest I do the split dosing. Yes.
You split day 1 and 8.
Day
right?
1 and 8.
Okay. Right. Okay. Thank you very much, Anja. If you stop your screen share so I can share mine.
I'm sorry. I will that.
No, fine. It's perfect. I somehow can share mine, but yes, I hope you may be able to see my screen. And yeah, thank you very much for your presentation. Thanks all to the speakers for their presentation and cases. I think it's always fun to do those cases because you really can address those clinical practice we have, which are not always reflected in the trial designs. So we are fighting with many more problems in daily practice where we have to adapt all those trial data to our clinical life. Now, thank you very much for joining this discussion. It was very exciting. We had many people staying from the beginning until the end. I'm very grateful for that. And thank you very much again for the sponsors who sponsor this event. Those 4 companies, I have to mention, they had no influence at all on the presentations or the discussions. And finally, I want to thank Medicongress for the excellent technical support. It really worked well. And finally, and with this, I will close, for all those who want to review the session, and for all those who were registered and hadn't registered but want to see the video of this seminar, of this webinar, it will be available to review for the next 6 weeks on the website where you have registered. So if you missed something, if you had to go to the toilet and or other reason leave this webinar, you can always come back and see the rest of it. Also, if you have missed the meeting altogether, you can tell all the other colleagues and friends, and you've liked it, to watch this meeting by going to the website and have and review what we heard today. Thank you very much to all of you, and have a nice evening. You don't need to have a safe trip home, but many of you are already there. Thanks once again, and see you next time, next date, 2020, with the same kind of webinar. Bye-bye.